Good afternoon. I have to applaud you all for staying in here when it's so nice outside today. So pediatric renal disease is rare, but unfortunately pediatric nephrologists are few. So those of you who thought you were rid of children when you finished your pediatric rotation in medical school may have a surprise coming your way. When we last did our workforce survey for the American Society of Pediatric Nephrology, there's about 250 clinical FTE serving all the children in the United States. So there are entire states without pediatric nephrologists. So the odds are likely that sooner or later, some child will come to your doorstep. What I get lots of phone calls about are about nephrotic syndrome and hypertension. So we're going to talk about that today because I think those topics will be most germane. So let's do the first case. This is a healthy 2-year-old. She comes to the pediatrician. She has a runny nose. She has a little bit of periorbital swelling. People think, well, maybe she has a virus. They prescribe Benadryl because Benadryl is the elixir of the gods for pediatricians. Her symptoms kind of wax and wane over the next week, and then she turns into the Michelin Man and is brought in for further evaluation. She has a normal blood pressure. Her weight's way up over the last week. She indeed has the periorbital edema, but now has abdominal fullness and has some GU and lower extremity swelling as well. She has normal kidney function, profoundly low serum albumin. Her urinalysis shows lots of protein and fat in it, and her urine protein to creatinine ratio is markedly elevated, and she, of course, has nephrotic syndrome. So first, pediatric definition. In adults, you think about proteinuria, you think about 3.5 grams of protein a day. Kids, of course, come in all sizes, so we have to define nephrotic range proteinuria based on their size. Generally, you say more than 50 mg per kilo per day. It's more than 40 milligrams per meter squared per hour if you want to think in terms of surface area. That's about 10 times the normal amount of protein excretion, so profound protein excretion. Hypoalbuminemia, serum albumin's less than 2.5. And I have to say, with kids, it is not rare to see serum albumin levels hovering around 1 and even lower than 1. So they can get profoundly hypoalbuminemic. Hyperlipidemia, again, most kids, it's rare for cholesterol levels to be more than 180, and we'll see cholesterols more than 200 in most of these kids. And of course, edema. Just a word about congenital nephrotic syndrome. By definition, this is nephrotic syndrome that's diagnosed in the first 3 months of life. If someone calls you about a kid with congenital nephrotic syndrome, run as fast as you can in the other direction. They are the most difficult types of nephrotic syndrome to take care of. They generally follow one of 3 subtypes, either related to an intrauterine torch infection, incredibly rare to see one of those kids nowadays, or related to a defect in a podocyte, the podocyte protein nephrin, what was classically called the Finnish type of congenital nephrotic syndrome, and the gene mutation in the NPHS1 gene was described a few decades ago. Or it's related to another podocyte protein or a WT1 mutation when seen with Dennis-Drash syndrome, or a LAMP2 mutation with Pearson syndrome. These kids are incredibly difficult to keep alive, especially the kids who have the Finnish type or the nephrin mutations. They need essentially daily albumin infusions and diuretics to maintain their volume balance. They're profoundly low in their IgG levels because they're losing all of that in their urine as well. They need thyroid supplementation. Most of these kids, we try to get by medically managing them for about 6 months of life until they're big enough where it's easier for us to do PD, and they're more likely to do well on the PD. And we aim for early transplantation about 1 year of age. Kids who have congenital nephrotic syndrome unrelated to Finnish type, you can sometimes get by with other maneuvers, decreasing their GFR with NSAIDs, unilateral nephrectomies. The kids with the Finnish type, really difficult to treat. What we're faced with more commonly, though, is idiopathic nephrotic syndrome. And we generally say, it's a rare condition. If you're a busy pediatrician in your practice over the course of your career, you may have 1 or 2 kids with nephrotic syndrome come your way. So about 1 to 3 new cases per 100,000 children per year in North America, prevalence of about 16 cases per 100,000 children. Most kids develop nephrotic syndrome preschool years, and it tends to be more boys than girls at that age, going towards even gender balance by adolescence. This is a recent, very well-done epidemiologic look at nephrotic syndrome from France, which kind of confirms the numbers that I just quoted there. It shows the annual incidence of nephrotic syndrome by age, and you can see it's very much presentation in preschool children, and then drops down to very low levels by the time you get into middle school and older. And again, the same gender predisposition for boys having more frequent nephrotic syndrome when they're young was borne out in the French study as well, with more even distribution between girls and boys as you get into adolescence. Now, we say that most kids who present with nephrotic syndrome will have minimal change disease, and we've said that for decades. But the evidence behind that goes back to this international study of kidney disease in children. This was a multi-center study from around the world where about 600 kids were biopsied when they showed up with their nephrotic syndrome. And we use it in pediatric nephrology as our benchmark study for nephrotic syndrome. It showed that 80% of kids with nephrotic syndrome will have minimal change disease. About 10% have FSGS, and the other 10% is split between the other causes. So you'll see that, unlike adult nephrology, membranous nephropathy is not up there. We, of course, are always worried about the 10% who might have focal sclerosis. A lot of questions as to whether we can characterize the different diseases at clinical presentation, and of course we can't. Although kids with focal sclerosis are more likely to have hypertension, microhematuria, and elevated serum creatinine than kids with minimal change disease when they present, since you're 8 times more likely to run into a kid with minimal change than focal sclerosis. You're more likely to find a kid with hypertension, microhematuria, or a higher creatinine who has minimal change disease than focal sclerosis. We start kids empirically on steroids for their nephrotic syndrome. Why? Because we're playing the odds. So 80% of the prepubertal kids are going to have minimal change disease, which responds to steroids. And by adolescence, even though the proportion of kids affected who will have minimal change disease is less, it's still about 60 to 65% of the adolescents who will have minimal change as well. We'll also start someone on steroids if they have normal blood pressure, a non-nephritic urinary sediment, and normal kidney function. What dose do we use? And again, this was defined by that international study. We started a dose of 60 milligrams per meter squared. That's 2 mg per kilo per day, up to a max of 80 milligrams. We give that daily for 4 to 6 weeks. After the 4 to 6 weeks, if someone has gone into remission, then we go down to 2/3 of that dose on alternate days for another 4 to 6 weeks. And then most of us will then wean the steroids off over an additional 4 to 6 weeks. This is a big sort of problem to get parents, their mind wrapped around the idea that we're going to give their child a medicine for a long period of time. Most of them are healthy kids. Most of them are used to 5-7 day courses of antibiotics, and they're done with it. So especially when we're telling them that you have to take a medicine like prednisone, you have to take it for 4 months to begin with, this can cause a great deal of angst. We also stress that nephrotic syndrome in kids is a relapsing condition. And when the kids relapse, especially the first few relapses, we go back to that higher dose. Although we don't keep them on the medication for as long, we'll convert them to alternate day dosing after they're negative or trace for 3 days. And I usually will get them off steroids within about 6 weeks. But again, a lengthier exposure to medication than what most families are used to. Kids respond to steroids very quickly. So if you give a child with nephrotic syndrome steroids, most of them will respond within the first 10 days. About 90% of kids who will respond to steroids will have responded by 4 weeks. And it's only a small proportion of the steroid responsive kids who take up to 8 weeks. By convention, we call someone steroid resistant in pediatrics if they haven't responded to 8 weeks of steroids. So it's a much smaller, much shorter exposure to steroids to meet that definition than in adults. We treat them supportively with a no added salt diet. We restrict their fluids, since most of them are going to respond to steroids pretty quickly. With fluid and salt restriction, we can keep their volume balance in check, so we don't have to use diuretics. In some of the children, especially if they haven't been diagnosed for a while, and especially the ones who have profound hypoalbuminemia, they will be so edematous and so uncomfortable that we do use albumin infusions more to treat their symptoms than anything else. And it can be quite helpful for the kids who are profoundly edematous. Again, as I alluded to, one of the first things I tell families when I'm counseling them about nephrotic syndrome is that this is going to be a problem that continues to happen throughout childhood. In our own experience here in Boston, it mimics what's been reported in the literature. When I looked at kids over the last 30 years who presented with nephrotic syndrome, only about 10% of them have no further relapses, or what are called primary responders. About 20% of them are infrequent relapsers, meaning that they'll relapse fewer than 4 times in a year. But 2/3 of the kids are either frequently relapsing or steroid dependent. So you're talking about an ongoing need for lots of steroids and the potential for a lot of steroid-related sequelae. We teach the parents to test their kids' first morning void at home, so we'll pick up relapses before they become more problematic. We try to anticipate flares. A lot of times infections or allergic triggers will precipitate a flare. We make sure that they get their influenza and pneumococcal vaccines, and then otherwise we're doing a lot of close follow-up looking for serious steroid side effects. When do we biopsy a kid? Well, if they have gross hematuria, hypertension, or renal insufficiency, that's rare and minimal change disease, so we'll biopsy you if you have that as a presentation. If you're steroid resistant, so I showed in that pie diagram about 10% of the kids will be steroid resistant from the get-go. Then, of course, we have a greater concern for an aggressive form of nephrotic syndrome like FSGS, and we need a histologic diagnosis. If they're steroid toxic and we're considering certain second-line agents, then some of us will biopsy to confirm the diagnosis and the histology. Again, oftentimes families really want to make sure that we're dealing with a specific diagnosis before giving their children some of the medications that we may recommend. And lastly, we always offer a biopsy in adolescent patients because we're a little less likely to see minimal change disease. I will say that most of the adolescents will decide to empirically try steroids to try to avoid a biopsy, however. Historically, the major second-line therapy you'll read about used in kids with nephrotic syndrome has been cyclophosphamide, and in Europe, chlorambucil, so alkylating agents. Both of these were the mainstay of therapy for many decades, and there are all kinds of literature showing how effective they are, including this study showing how exposure to Cytoxan or chlorambucil, results in a significantly decreased risk of further relapses. The German group in the 80s helped us to define the best dose of Cytoxan, which is 2 mg per kg per day, and the duration of treatment for about 12 weeks. And I put this reference in here just in case anyone ever wants to look that up. Unfortunately, cytotoxic agents like chlorambucil and cyclophosphamide have a whole bunch of side effects. We worry most about leukopenia, infection, and gonadal toxicity. And it's led to there being increased interest in other potential second-line agents. Although there is still definitely a role for the use of cyclophosphamide in kids with minimal change disease who may not be doing well with these other second-line therapies we use today. And the response, especially in kids who are frequently relapsing, can be very dramatic, with 2/3 of them usually remaining relapse-free 2 years after they're given their Cytoxan. What's replaced Cytoxan as the most used second-line therapy for minimal change disease in North America is MMF. And prior to MMF, azathioprine was used by some pediatric nephrologists as a steroid-sparing agent. But with the advent of MMF and its use in the 90s in renal transplantation, and then its use in lupus and nephritis, people became increasingly comfortable using it in kids with minimal change disease. This was one of the early reports looking at a group of 33 kids, showing how efficacious it was, with 75% of those kids being in remission while they were on their MMF, and 35% maintaining a long-term remission. When I use MMF, I usually use a dose similar to what you use with transplant, so 600 milligrams per meter squared per dose twice a day. I'll usually plan to use the MMF for about 18 to 24 months as monotherapy, so I try to wean the kids off the steroids. Pediatric nephrotic syndrome tends to be most active during the first 2 to 3 years after presentation. So if a kid progresses to using MMF, I'm hoping that by maintaining them in remission on the MMF, their nephrotic syndrome will naturally become more quiescent. And when we withdraw, they're less likely to have problems. And I've been very successful, and we find here that about 2/3 to 3/4 of our kids do quite well on MMF when they need a second-line agent. The French have reported their experience recently again, and it mimicked the early reports that we saw from the US. Well, other sorts of therapies are used for minimal change disease. Now, often the choices are kind of provider and center specific. There's a lot of focus in the US on the use of calcineurin inhibitors. I think that comes from pediatric nephrologists being comfortable with their use in kids with renal transplantation. I'll have to say, though, that for kids with minimal change disease, it's the rare kid with minimal change disease that really needs cyclosporin and tacrolimus. It usually takes a bit of time and effort and hand-holding and finessing steroids to prevent people from automatically wanting to progress to calcineurin inhibitors. I think it's relatively few, the number of kids with minimal change disease, who need to be exposed to calcineurin inhibitors. There's increasing use of rituximab, especially in kids who may not have done as well with MMF as one would have hoped. There's a nice report that was first published 5 years ago from Japan. 24 kids who had frequently relapsing or steroid-dependent nephrotic syndrome compared to an equally sized control group. And it showed that the kids who got rituximab, here in blue, were significantly more likely to stay in remission, so 2.5 times more likely, or 2.5 times the amount of time they'd be in remission before they were likely to relapse than kids who had placebo. And after the kids got rituximab, although this entire group was either steroid dependent or frequently relapsing, they were significantly less likely to revert back to being frequently relapsing or steroid dependent. So many of us have been using rituximab in kids who don't do as well with MMF prior to progressing to Cytoxan or a calcineurin inhibitor. About 90% of children who have steroid-sensitive nephrotic syndrome will go into long-term remission by late adolescence or early adulthood. There are studies, again, from France that show about 30 to 40% of individuals who've been diagnosed as a child with nephrotic syndrome will have at least one relapse as an adult. Although these patients tend to be very responsive to steroids as adults and tend to go rapidly into remission and very, very infrequently have repetitive relapses. As with most renal diseases, the steroid responsiveness of pediatric nephrotic syndrome almost always portends good long-term GFR. On the other hand, we worry the most about our kids who don't respond to steroids, and they're having focal sclerosis, which is found in about 40% of kids with initial steroid resistance. Focal sclerosis is the most common glomerular disease in kids leading to ESRD, and it's the most common cause of ESRD in African American children in North America. Failure to respond to steroids, massive proteinuria, hypertension, all poor prognostic signs, as you could imagine. And end-stage disease usually occurs quite rapidly in kids who are unable to achieve at least a partial remission of their FSGS. FSGS in kids resistant to conventional therapy, about a third of kids with FSGS will show an initial response to steroids, but they almost always become resistant very quickly. There's no clear benefit to cytotoxic agents with FSGS in kids. Calcineurin inhibitors have been the mainstay of therapy. There are reports going back almost 30 years now showing efficacy in about 70% of kids. Generally, it leads to partial remission with improvement with their volume imbalance, which makes a profound difference in their quality of life. So these kids are able to go back to school and daily activities, even though they continue to have heavy proteinuria, and most of them will ultimately lose their renal function. The NIH-sponsored FSGS multi-center trial consisted of about twice as many kids as young adults. It again showed some efficacy to a calcineurin inhibitor-based protocol. Dr. Hildebrand has talked to you about the role of genetic studies, and I'm not going to belabor at this point, but obviously very young children with steroid-resistant disease, we worry the most about them having a genetic underpinning to their nephrotic syndrome. Mutations are also more commonly found with consanguinity. And we're increasingly using genetic tests up front in kids with nephrotic syndrome who don't respond to steroids empirically to see if they have a genetic mutation, since they're less likely to respond to other immunomodulatory agents, and we can spare them this exposure. I'm going to skip this because I think Dr. Hildebrand talked about it. So clinically, when do we consider genetic testing in nephrotic syndrome? Again, certainly any baby with congenital nephrotic syndrome or onset in the first year of life will do genetic testing on. If you have a family history, if you're unresponsive to therapy, or if you have FSGS on your biopsy, and especially if you're young, or if your nephrotic syndrome presents with significantly decreased GFR. So we're going to shift gears now and move from the realm of nephrotic syndrome to the realm of hypertension. This is a case of a 10-year-old boy. He's moved to the area. He's being seen for an initial well-child visit with his pediatrician. He was born prematurely. He needed to be in the NICU for a few weeks on a ventilator. He otherwise has done fairly well, although he had febrile illnesses as a young child, diagnosed as ear infections, and he's had less optimal medical care during his childhood. On exam, he looks good to you. He's grown well, but his blood pressure is 130/82. He comes back a couple weeks later, and his blood pressure is still in this range. He has normal kidney function. His urine's benign. A renal ultrasound shows that he has a smaller right kidney that has focal scarring, and a VCUG shows that he has right-sided reflux. So this is a case of reflex nephropathy. So what's hypertension in kids? Well, if you're a pre-adolescent, so if you're younger than 13 years of age, hypertension is defined statistically in pediatrics. So we compare your blood pressure to what your blood pressure should be based on a normative group of kids of your same gender, age, and size. Normal blood pressure is less than the 90th percentile, elevated blood pressure 90th to 95th percentile, stage 1 hypertension greater than equal to the 95th percentile, plus 12 millimeters of mercury, and stage 2 hypertension is when you exceed that 12 millimeters of mercury. For adolescents, we use the same definitions now as adults. So there have been various task force in pediatrics looking at hypertension and defining hypertension in children and adolescents. The most recent group published their results in 2017. They tried to align the classification of hypertension more with classifications that the AHA and ACC had made, and they streamlined recommendations for initial evaluation and management, and also increased the reliance of ABPM in pediatric hypertension evaluation. If you look at these guidelines, they're very detailed. There's 30 action statements and 27 recommendations and all kinds of strength of recommendations. So if anyone wants to look at them, you'll have to spend a fair amount of time. What's most interesting I found about this were the new normative blood pressure tables, which are available for the kids who are younger than 13 years of age. These blood pressure tables are based on auscultation of blood pressure in 15,000 normal weight children. So it's, it's a huge group that was used to norm blood pressures. And again, standardized for gender, age, and height. If you look at these tables, for instance, this is a table for systolic blood pressure for an 8-year-old. What you do to begin with is look at the child's height and see what percentile they fall at, and then you can read down as to whether they have elevated blood pressure, stage 1, or stage 2 hypertension, or their blood pressure is normal, depending on where they fall out in these charts. As you can imagine, these charts can go on for several pages. There's this very nice simplified screening table. So if any of you ever have to be involved with blood pressure screening for camp physicals or school physicals, or roped into one of those community service obligations, I would urge you to Google this simplified screening table and use this, because it allows you to really pick up most of the kids who are hypertensive without having to rely on those more complex tables all the time. About 60% of the kids who are referred to our hypertension clinic are normotensive, and the vast majority of those kids were called hypertensive because their blood pressure cuff was incorrectly sized when their blood pressure was checked either at school or at their primary care physician. So especially in obese or really muscular adolescents, there's a tendency to use too small a cuff. In some of our more obese younger kids, people will often underestimate the size of the cuff that needs to be used. So you want the cuff width to be greater than 40% of the arm circumference at the midpoint between the olecranon and the acromion, and you want the bladder length, so inside the cuff, the rubber bladder inside the cuff, to exceed 80% of the arm circumference. What about oscillometry versus manual blood pressures? I find it's increasingly difficult for me to find a manual blood pressure device anywhere outside of the renal clinic at Children's Hospital. I'm sure you all find this in your home facilities as well. A great sort of reliance on oscillometry. Now, Dr. Park, God bless him, took 7,000 children, and he measured their blood pressure by auscultation and also by oscillometry. And he was able to show that oscillometric readings overestimate your blood pressure, average about 10 millimeters of mercury systolic, 5 millimeters of mercury diastolic. So again, oscillometry is a wonderful screening maneuver, quick, easy to do. But if a child is hypertensive, you really need to confirm their blood pressure by auscultation. And keep in mind that these oscillometric readings are probably going to be a bit higher than what you would get with auscultation. So why do pediatric nephrologists take care of kids with hypertension? Well, historically, if I go back to when I was doing my fellowship in the early 90s, the bulk of kids who had pediatric hypertension would have renal parenchymal disease, most of them reflux and scarring of their kidneys. And then the next piece of the pie was renal vascular hypertension. Primary hypertension wasn't commonly encountered, or other causes of hypertension, especially cardiac causes, weren't that common. What we've seen over the last 30 years is a giant shift, so that now obesity-related hypertension takes up the huge chunk of the pie, and parenchymal lesions are being seen less and less frequently, potentially because we're getting better at diagnosing and preventing the adverse consequences of reflux. Obesity, huge problem in adults, huge problem in children. Right now, the prevalence of obesity has increased threefold since the 70s in kids. About a fifth of kids who are school age meet criteria for obesity, and certain portions of our community have even higher rates of obesity. The Bogalusa Heart Study is kind of like the Framingham Heart Study in kids, Gulf Coast of the US, showing that obese kids have significantly more risk of hypertension. And there's another quite nice blood pressure study out of Houston looking at adolescents that shows that obesity in adolescents similarly predisposes to hypertension. What do we do when we have a kid in front of us who we are concerned may be hypertensive? Well, of course, their history is focused on potential insults to their kidney, in addition to noting their weight and their obesity issues. So we look at their current illness. Do they have an illness that might be causing hypoperfusion or hypoxia and renal ischemia? We ask about their birth history and prematurity, especially if they may have had umbilical lines in and potential for having had some sort of infarction to an area of their kidney. We talk about illnesses, whether they've had UTIs, whether they had a lot of undifferentiated febrile illnesses as young children that potentially could have been undiagnosed UTIs with reflux in place. We will ask about family history. We ask about medications, especially stimulant medications in the older kids, OCPs, decongestants, although I'll say, most medications will cause only mild hypertension, if any hypertension. And then, of course, the review of systems looking for a lot of the catecholamine-associated symptoms. Kids who are significantly hypertensive, so if you've been really hypertensive for a while, you tend not to grow well. So we always like to look at growth curves as pediatricians. We look for unifying syndromes. So we look to make sure that someone couldn't potentially have Turner syndrome or Williams syndrome or Marfan syndrome. And, every year we catch a few of these kids in our hypertension clinic because we're looking at them with a different eye. We do 4 extremity blood pressures on all of these kids. You never want to miss a coarctation. The oldest patient who I've seen at Children's Hospital with a coarctation was actually a 72-year-old woman who was admitted by the cardiologist, and then we were asked to consult on her. She was lovely, but I don't really want to see 72-year-olds every day. But there were many opportunities for people to feel her absent femoral pulses through those 72 years. Who needs immediate care as a child? So if you have stage 2 hypertension levels, so that's 95th percentile and more than 12 millimeters of mercury above that, and you're symptomatic, you should be sent to the ED. Otherwise, if you're more than 30 millimeters of mercury above the 95th percentile, or your blood pressure is more than 180 over 120 as an adolescent, even if you're asymptomatic, you should go to the ED. What do we do for a hypertension evaluation in kids? We check their urine, we check their electrolytes, focusing on their potassium and bicarb for signs of renin and aldosterone. We check their renal function, lipid profile, and then if they're young, renal ultrasound, or if they have an abnormal urine or creatinine. Obese kids, there are recommendations to do screening for glucose lability, for fatty liver, and in select kids, the guidelines talk about other sorts of testing being done. Ambulatory blood pressure monitoring is now recommended in kids if they've been in that elevated blood pressure category for more than a year, or if they meet the criteria for stage 1 hypertension. These are the kids who are most likely going to be found to have white coat hypertension and potentially can be spared further ongoing evaluation through the ambulatory blood pressure monitoring. In certain kids and adolescents with high-risk conditions, we do ambulatory blood pressure monitoring, and certainly our kids with end-stage renal disease, we're doing for both our dialysis and transplant kids, regardless of how well their blood pressure seems to be controlled with casual measurements. Follow-up testing for the hypertensive kids are usually guided by what comes from that initial diagnostic evaluation. And usually the kids will shake out into one of 3 categories. A suspected primary hypertension. So these are kids who tend to be heavier kids, deconditioned kids, family history of primary hypertension. Kids where you suspect renal parenchymal disease, they've had renal insults in the past, or they have something in their history to make you think that they've, or their evaluation to show that they've had some renal parenchymal damage. And then lastly, the kids with still with unclear etiology, in which case we sometimes will progress to other sorts of imaging studies. We do DMSA scanning, looking for renal scars more frequently in kids, and certainly CTA and angiography is something that we use in kids much as they're used in adults. CTA is becoming more and more useful. Kids are more likely to have stenotic lesions in branching vessels, so for many years we still had to rely on angiography because the technology wasn't allowing us to get as good a look at the more distal vessels, but I have to say the imaging improved to the point that we do use CTA for first-line screening in almost everyone. Pharmacologic therapy is very similar to how you dose adults. So we use lots of calcium channel blockers and ACE and ARBs. They're often the best tolerated. Things like diuretics. Kids don't get to run to the bathroom whenever they want at school. They don't want to take their diuretics at school. So calcium channel blockers, ACE and ARBs. We try to use less than a full dose. We'll use pediatric dosing. Most of these agents have pediatric dosing defined, titrating up as we're needed and aiming for a blood pressure less than the 90th percentile or less than 130 over 80, whichever's lower. Our goals of therapy is to use the lowest doses of the least medicines, use non-pharmacologic adjuncts, so diet, exercise. We talk about all of that as well. The new guidelines do recommend echocardiography if you're treating a child, or if they had an abnormal initial echo and you're following them up. So again, we're doing more echoes than we once did with kids with hypertension as well. So we'll shift gears now and do some questions. So, previously healthy 4-year-old boy presents with periorbital and abdominal swelling. His normal blood pressure is serum creatinine 0.3, serum albumin's 1.5. His urine is 4+ protein and trace heme. Which of the following would be your best next step? Is it A, renal biopsy to define histology, B, genetic studies for nephrin and WT1, C, screen for HIV and hepatitis, D, empirically starting steroids, or E, starting diuretics? Poll. Oh, well, we'll just move on. We'll skip that. So answers the D, starting the steroids empirically. So, this kid presents in the pretty typical fashion for minimal change disease that I talked about. The vast majority of these kids will be steroid responsive. I talked about how the WT1 and nephrin mutations would be things that we'd worry about in a young child, so a baby presenting with concern for congenital nephrotic syndrome. We relatively rarely see hepatitis or HIV, secondary causes of nephrotic syndrome, in young kids, and so it's not part of routine screening unless there are specific risk factors. And I talked about how since kids tend to be very responsive to steroids and respond to their steroids quickly, we can get away without diuretics. So question 2. This very swollen 2-year-old girl with nephrotic syndrome diagnosed 3 months ago. She's completed 8 weeks of high-dose steroids without improvement. A kidney biopsy shows FSGS. And your best next management step would be pulse steroids, genetic testing for podocyte mutations, plasmapheresis, or an oral cytotoxic agent. And the correct answer here would be genetic testing. So this is a young girl. We talked about how genetic mutations underlying nephrotic syndrome are more likely to be found when you're young and you have FSGS on your biopsy. In terms of the other choices, although high-dose IV steroids have been used as part of some regimens for therapy-resistant FSGS, most pediatric nephrologists use a calcineurin inhibitor now for preferred immunomodulatory therapy. Plasmapheresis we use a lot with recurrent post-transplant disease, limited data as to its efficacy in kids with this scenario. And lastly, 10-year-old girl, she's otherwise been healthy. She comes in for a visit. Her blood pressure is 130/80 by automated blood pressure machine. Which of the following would be the best next step? Getting a perinatal history, asking about a family history, doing 4 extremity blood pressures, doing a blood pressure by auscultation, or doing a renal ultrasound with Doppler. So the first thing you'd want to do, since this is an automated blood pressure reading, is to confirm the blood pressure by auscultation. I shared with you those results showing that blood pressures by oscillometry overestimate blood pressures by auscultation in kids. And we'd want to confirm that this child has hypertension. And thereafter, most of those other steps would be good things to do. So in terms of take-home messages, for nephrotic syndrome, we talked about how most kids and young adolescents with nephrotic syndrome will have minimal change disease, can be treated empirically with steroids without a biopsy. Most kids respond relatively quickly to their steroids, so we begin to get concerned if they've been steroid resistant for 4 weeks, and definitely if they reach the 8-week mark. MMF, rituximab are all being used more often as second-line agents than cyclophosphamide now. And most kids with steroid-sensitive nephrotic syndrome will eventually outgrow their disease, go into lengthy periods of remission with few, if any, relapses as an adult. In terms of hypertension, again, I pointed out how pre-adolescent kids, hypertension statistically defined, not epidemiologically defined. The sizing of blood pressure cuffs can be very problematic. Renal parenchymal scarring is being seen less frequently as the cause of hypertension, and the epidemic of obesity is hitting kids as it is adults in terms of mediating high blood pressure. And we reviewed kind of a basic evaluation and how we rely on calcium channel blockers and angiotensin blockade. So there are some references for you. So I hope that gives you a flavor of both those topics. I hope it wards off people calling you about kids with those issues as well. Thank you for your attention.